Hello, dear virtual audience. I'm really happy to be here to welcome you to this symposium on HIV and aging sponsored by MSD. And with my co-presenter, we are very happy to talk with you about weight gain and aging and remind you of the risk factors to keep in mind. So let's go to the agenda. You're going to have two presentations. I will present the first one on women not on childbearing potential, and my colleague Luc van Gaal will talk to you about aging as a risk factor of weight gain for people living with HIV. And then we will have a question and answer session before the closing of our symposium. Okay, so let's go to the first presentation, which is about the woman not of childbearing potential. You have here my conflict of interest. So first of all, I would like to set up the scene and remember you about the epidemiology of women with HIV in Europe. You've got two graphs which have been updated with the data from 2019 by the ECDC and recorded in the annual report on HIV published last year. And I would like to draw your attention of what I've underlined with this red cycle, saying that from 2009 to 2018, the women in Europe and the whole of Europe, and especially in the European Union, there is a stability in the number of women diagnosed with HIV during those 10 years, and you can see that the proportion of women diagnosed late is higher than the proportion of men diagnosed late, and especially in older ages. And if we look at this picture, which is about the age-specific trends of diagnosis in women, you see that from 2009 to 2018, the rate of new diagnosis per 100,000 women is exactly the same in women more than 50 years old or women between 40 to 49 years old compared to younger age, where the rate of diagnosis is going down alongside the age, alongside the years. So there is really a problem, an issue with diagnosis in older women, and there is a real problem that we should try to explain. Why the rate of diagnosis in younger women is going down, and the rate of new diagnosis in older women is completely stabilized. So to talk about the challenges alongside the continuum of care in older women, I would like to address four main issues. First, weight gain, then menopause and comorbidities and side effects, and finish with a few words about mental health. So first of all, I would like to go back to what is weight gain with age and gender, and I wanted to remind you and share with you those data published 2 years ago about two cohorts of men and women, either infected or non-infected with HIV. And you see that the progression of BMI through the age on top, and the height circumference, and the weight and the ratio of waist to height down at the bottom right, you see that women have a higher BMI, a higher waist circumference and height circumference and waist to height ratio higher than men, and it goes up with the age. And if we look at the impact of weight gain and post-menopause, and especially the relation with antiretrovirals, we have talked a lot about dolutegravir, but I would like you to look at those two very recently published studies in AIDS, just a few weeks ago. Some data we have from etravirine and raltegravir, which is a French study called ETRO, where people were switched from either kind of antiretroviral, and they were switched to an association of etravirine and raltegravir, and the patients were virologically controlled, and there was a strong association observed with a decrease of ovarian reserve and weight gain, fat, and insulin resistance in women. And on the contrary, there was no weight gain in younger women. And if we look at rilpivirine and tenofovir or tenofovir lafenamide, the switch from rilpivirine, tenofovir disoproxil to rilpivirine, tenofovir lafenamide in virologically controlled patients, and the female gender was associated with the weight increased after adjustment on age. If we look now at some considerations as women when they enter menopause, it has been seen that menopause may be earlier in women living with HIV, and there is a bigger and higher number of menopausal symptoms in those women living with HIV, and the studies have linked sexual symptoms to depression, anxiety, and psychological distress, and I will go back to that a little bit later when I will talk about mental health. Menopause may also be an additive factor to HIV on traditional risk factors such as smoking, drug use or poor nutrition, and antiretroviral for comorbidities. And hormone replacement therapy has potential risks like thrombosis and cancer, but also benefits on symptoms and osteoporosis, and many are quite unknown for women living with HIV, and there is definitely a field to investigate for women living with HIV and getting older. And when we talk about ovarian reserve, we also talk about testosterone. And in this very interesting study, they have compared the quality of life and the association with testosterone. And you see here on this graph that the prevalence of testosterone insufficiency in HIV-positive women reached the rate of 37%. And it was associated with a decrease in sexual desire, physical activity, and physical function as well. And it was associated with an increase in mental fatigue, health distress, and clinical depression. And the difference between men with testosterone insufficiency and women without testosterone insufficiency was significant in most of those parameters. If we switch now to the other issue I've told you about, which is osteoporosis, the bone mineral density loss is maximal in women in the perimenopausal age, and it's correlated with a fracture risk in the general population. I will go back to the fracture risk a little bit later. The bone mineral density loss is also increased in HIV. So you see when you are a woman, peri or postmenopausal time, and HIV infected, the risk of bone mineral density is increased, and therefore osteoporosis is more prevalent. Risk factors also include IV drug use, cocaine, and race. And bone mineral density loss is also associated with antiretrovirals, especially tenofovir, and this effect is emphasized when there is an association between tenofovir and a boosted PI. Maybe tenofovir lafenamide may have a little less effect, but it has still to be investigated and confirmed. And we have seen on many studies that NRTI sparing strategies show less bone mineral density loss. And because there is this question regarding osteoporosis and bone density loss, and at the end bone fracture, there was also a question regarding the efficacy and safety of tenofovir lafenamide versus tenofovir disoproxil fumarate. And you probably all have in mind this very interesting meta-analysis performed by Andrew Hill that has shown that there is no difference, at least in safety issues regarding bone fractures, as you can see on this slide at the bottom of this graph. So does tenofovir disoproxil increase the risk of fracture. And we've got a very nice case control studies from the French hospital database on HIV performed between 2000 and 2010. And you see that there was no difference, there was no impact on tenofovir disoproxil fumarate on bone fracture risk at the end. So probably this question raised a little bit earlier is now answered. Tenofovir disoproxil fumarate may not be associated with an increased risk of bone fracture. Regarding now the issues of comorbidities and association with age and gender, from the HOPS cohort, you can see that there is a strong association between the number of comorbidities on the y-axis and the age. So you see that at the age above 51, which is postmenopausal time for women, the number of comorbidities can reach up to 3, and then in the woman age 61, it can be up to 4. And the gender is definitely a risk factor for a higher number of non-AIDS comorbidities, such as anemia or psychiatric events, especially for women. And when we switch to comorbidities such as cardiovascular conditions, this is a very nice study showing the number of cardiovascular comorbid conditions stratified by gender and stratified by age. And you see on the left side of the screen the age from 50 to 64 years old, and the difference between men and women between 0 to 3. And you see that in the age more than 64, women have a really higher risk to have a high number of cardiovascular comorbid conditions. And there is also a higher risk of high LDL and low HDL, a higher risk of hypertension, overweight, and obese situation compared to men. If we switch to the incidence of stroke regarding HIV status, here again, it's a study focusing on HIV-positive women, and the risk of stroke is multiplied by 2.39 in HIV-positive women compared to HIV-uninfected women, and this is really obvious in women more than 65 years old. Well, all those cardiovascular events are completely associated with the role of tobacco, and in this very nice exposed, non-exposed study comparing HIV positive and HIV negative women, you see that here in women with HIV and use of tobacco, the risk of comorbidities is really high, and as well as the risk of medications, and especially polymedications. And I will go back to the issue of polymedication a little bit later. Just before I go back to this polymedication story, I would like to highlight this study done in France, which target was evaluating the possibility of coping with ART side effect, and it's called the EVE survey. And you see from the slide that 43% of the women did not find any solution to their many symptoms, and when they have symptoms related to ART, there was an increased risk of ART self modification. And if you can go back to the paper, you will see that the side effects were more prevalent in older women than in younger women. And this is again these very interesting studies comparing women with or without HIV. And Donaldson had reported a clear effect of the number of comorbidity in HIV-positive women compared to HIV-negative women as a function of age. And you see that in a woman more than 50 years old, and especially more than 60 years old, the number of comorbidity was higher in HIV-positive women than in HIV-negative women. And again, this story about polymedication and psychological distress, I've shown you this polymedication slide, and you see that in HIV positive women, the rate of polymedication is going up and up with the age. And in this group of women, HIV positive and older than 60, there is a frequent diagnosis of depression, anxiety, and panic disorder with an odds ratio statistically different than in HIV negative women by 1.86. And in Spain, in another study in Spain, on phone interviews, 51% of women reported psychological distress, and it was associated with non-adherence to ART or non-use of ART. So I would like to conclude this presentation by a few take-home messages. First, the number of women diagnosed in older age in Europe is not decreasing, unfortunately, compared to younger women. And being a woman of postmenopausal age exposed to a high risk of weight gain, insulin resistance, and comorbidities, and because of those comorbidities, the rates of polymedication are increasing with age and include psychiatric drugs. And you have to remember that depression, anxiety is very prevalent in this population, and it may induce non-adherence. So more consideration should be brought to aging women health and address specific needs. And I think that a holistic approach is absolutely essential. And I hope that during the Q&A session, we'll be able to talk about what we call the holistic approach. Okay, so thank you very much for this first presentation and for being here with us. And I would like now to switch to the second presentation, which is aging as a risk factor of weight gain in people living with HIV. And I now give the mic to Luc Van Gaal. Thank you, Luc.
Good day. Thank you so much, Karin, for this kind introduction. I have been asked to discuss with you some aspects of aging and weight gain, facts, management, potential treatments. These are my conflicts of interest to disclose. To start with, we know that weight control has a number of challenges because of its complex pathophysiology, because of the targets and the expectations that are very difficult to achieve. We know that obesity and abdominal obesity in particular is associated with diabetes, sleep apnea, and cardiovascular outcome. And then we have very special aspects such as frail patients, specific age aspects, the aspect of sarcopenia, and the problem of the obesity paradox, which is a well-known phenomenon. Obesity is not only associated with a number of classical findings such as diabetes, ischemic heart disease, sleep apnea syndrome, but we all also know that it is associated with non-alcoholic fatty liver disease and also psychological aspects that may finally lead to aspects of depression and aspects that are related to the psychological behavior. If we look to details about the age, these are data that recently have been published in the Frontiers of Endocrinology, and you can clearly observe that there is a difference in the age distribution for overweight and obesity, in that in men, real obesity mainly occurs around the age of 40 to 50, whereas in women, you will see that it is mostly beyond the age of 60 up to 70, 75 that we see occurring the most overweight, but also the most aspects of real obesity. If we consider obesity, not all fat is the same, and for that reason I use here a CT scan of the abdominal region, and I have two ladies to present to you. Maria, who has an almost normal amount of intra-abdominal fat, and she has a perfectly normal metabolic profile, whereas another patient, which is called Claudine, you immediately can observe that she has 3 times more deep intra-abdominal visceral fat, and she's characterized by a number of metabolic abnormalities and this metabolism, such as high cholesterol, high LDL, hormonal dysfunction, hyperglycemia, and so on. Again, looking into age, and then in particular looking to that aspect of visceral fat, and we use here, as was published in a review paper, the visceral over subcutaneous adipose tissue ratio, that you will see that for women there is an almost close relationship. And this is based on the number of trials that have been put together here, more than 350 trials that were analyzed. But in men, you see a more curvilinear and an aspect that goes beyond that linear aspect. So slightly different for men and for women if you consider the relationship between visceral fat and age. Another important aspect that we are confronted with is ectopic fat. Ectopic fat is accumulation of fats in tissues and in regions where it normally does not belong. In the abdominal area, in the liver, in the muscle, in the heart, and finally also in the beta cell. And this so-called ectopic fat contributes to diabetes, to diabesity, to insulin resistance, to premature endothelial dysfunction and atherosclerosis, and also to an accumulation of ectopic fat at the level of the heart, epicardial fat. And we know that this is contributing to heart failure, a phenomenon that we very often observe in patients at risk. This has to do with two types of adipocytes, the healthy versus the unhealthy adipocyte. And the unhealthy adipocyte is mainly characterized by pro-inflammatory markers such as cytokines TNF-alpha, resistin, MCP, and toxic lipid species. And what is particular on this unhealthy adipocyte, it is the more larger, the more hypertrophic type of adipocyte, which is mostly found in people gaining age. The older the people become, the more hypertrophic that abdominal fat and that abdominal adipocyte will become. We also have to look into the unmet clinical needs, is that we have to look beyond the classical risk factors such as LDL, blood pressure, and smoking. We have to look into the components of the metabolic syndrome where abdominal obesity together with insulin insensitivity and cytokines play an important, a crucial role in that phenomenon. And they may contribute to type 2 diabetes on one hand and to cardiovascular disease on the other hand. An easy way to screen and to identify patients with that so-called metabolic syndrome, where, as you can see, age is one of the important contributors, also very often found mainly in men, is just taking together the waist girth circumference together with triglycerides. So if you would like to screen your individual patients and your HIV patients are definitely at risk for the metabolic syndrome, so measure the waist circumference and your triglycerides. If they both are elevated, then you have a patient, certainly patients living with HIV, then you have such a patient at risk. And if we look to an update on the American ENHANCE data and looking into risk factors for the metabolic syndrome, we find there age, BMI, smoking, and also the menopausal status, which is an indirect representation of patients becoming older. So this plays also plays an important role. If we then look in detail to the prevalence of that specific aspects, you will see that metabolic syndrome is by the age increase almost present in 70% of the individuals over the age of 65. The same is true for the high waist to height as well as to the high waist to hip circumference. So this is the prevalence according to the age group. And if we then bring diabetes into the picture and into that specific project, we know that there is a worldwide prevalence of diabetes also increasing by age. These are not only the actual data of last year, but also projected prevalence in 2030 and 45. So knowing this worldwide increasing epidemic of diabetes, if we can stop the diabetes development in patients at risk, such as patients living with HIV, I think this is an important task and an important driver. Another expression of that metabolic syndrome may be non-alcoholic fatty liver disease, and we observe that expression of inflammation at the level of the liver in patients with obesity, in patients with the metabolic syndrome, in patients with diabetes, but also more and more known in individuals living with HIV. So this is another expression of that metabolic syndrome. Very important is drug therapy. And we know that there is a large number of classes of drug therapies that are known with weight increasing capacities. The hormones are well known to that. We know that already for decades. But in terms of energy metabolism, beta blockers are associated with weight increasing capacity. And we know that if your patients with the metabolic syndrome will develop hypertension, beta blockers will be prescribed. If they develop, patients living with diabetes or even without diabetes, if they develop neuropathy, what we also see in HIV individuals, anti-epileptics are prescribed, but they may give weight gain. Patients becoming depressed, some doctors prescribe second-generation antipsychotics, well known for weight increasing capacity. And then finally, also classical older anti-HIV treatments may be involved as well. And we know that that this aspect, that some integrase inhibitors and also TAF may be associated with weight gain, but these are the older treatments not that often used anymore, and the more modern drugs do not have that important weight gaining capacity. So you see also what patients receive in terms of drugs is an important phenomenon. If this brings us to the HIV-related chronic immune activation, you will see that metabolic syndrome with its specific components play an important role, where the CD4 dysfunction plays a role, where again these cytokines and adipokines plays a role, coming from whenever, but also coming from the adipocytes, and even microbial translocation is an important driver of the metabolic syndrome. So all aspects we have to think about when considering our patients. So this has a number of consequences and recommendations. So for patients living with HIV, I advise to close follow up these metabolic consequences, to give them advice about healthy food and lifestyle, not only for what they eat and how they move, but also thinking on smoking aspects, on sleep, which is associated with obesity, etc. That doctors should choose an ARV regimen which will not add another risk of weight gain, knowing that age is already one. That maximal treatment of other risk factors with metformin, statins, ACE inhibitors to target levels just to avoid that risk profile is important. And certainly we know that patients in this actual epidemic of the COVID-19 infections, we should look into preventive measures there as well, because obese individuals will have a high risk to have a bad cardiovascular outcome. And then the specific follow-up parameters we have to look after in patients living with HIV is BMI, waist and hip circumferences, looking into fasting glycemia or performing an OGTT, looking into their lipid profile and other metabolic consequences linked with inflammation, linked with procoagulation and other aspects that may explain the risk that we observe. This brings us as last point to the overall obesity management. A good and appropriate obesity management starts with good assessment, looking into family background, medical history, previous patients' attempts, medication intake, as we explained, making the difference between healthy versus unhealthy obesity, linked with body fat distribution, patients' expectations, hormonal profile, etc. So these aspects are important. And we cannot enough underline that if we go with a 5 to 10% weight reduction, that we have not only important aspects of quality of life, but also for mortality. Look to this cartoon where you will see that we go into 40, 50 to 60% either a resolvement of a number of these complications, and that for some aspects such as diabetes, hypertension, there even can be a resolution found if you go beyond the 10% weight reduction. So these are important aspects. GLP-1 receptor agonists, one of the newer approaches and peptides, are known not only to have nice effects on glucose control, on blood pressure control, but they also have neuroprotective capacities, also having an effect on appetite reduction, which will finally result in aspects of weight reduction without major complications. Liraglutide, one of these GLP-1 receptor agonists, by the way, has extensively been studied in elderly individuals, also in those with a risk for sarcopenia, and this paper shows that there is indeed a high efficacy in fat loss specifically. However, some people will finally also advise surgery. For surgery, we have to be very careful because data from a number of studies have clearly shown, as this slide indicates, that over the age of 65, the proportion of mortality ratio is higher. And this is probably also explained by the fact that elderly individuals may become frail, may have muscle loss, as sarcopenia illustrates, and this is work that we presented a number of years ago in obesity reviews, where we explained that sarcopenia, also to some extent driven by aging, may give rise to insulin resistance, to diabetes, to cardiovascular outcome, and also to non-alcoholic fatty liver disease. And this has been shown to explained also in outcome. These are the adjusted hazard ratios, even in obese individuals who have a sarcopenic profile, that total mortality is higher than in just obese individuals or normal individuals. So obesity together with sarcopenia is an important role for a cardiovascular and total mortality. So dear colleagues, ladies and gentlemen, I hope with this short overview that I have convinced you that early treatment and early prevention and screening for a number of the cardiovascular risk factors, going from overweight obesity, intra-abdominal obesity, but also going over the liver and NAFLD into sarcopenia, are important aspects that we should look after very early in your individuals living with HIV, because with prevention we can prevent these patients from a bad outcome. And it is with this final message and recommendation that I would like to thank you for your attention.
Okay. So we are very happy to have you online, Luke and I, after those two presentations. We are starting to get the questions. Okay, so we just got some problem with the noise, but it looks like it's fine now. So I would like to start the Q&A session. Okay, so now it's fine. Okay, so shall we start with the questions? Okay. So I have a questions for you, Luke. We've got some questions through the One Air platform, and I'd like to to ask you a question from the audience, which is addressing the issue what to measure and with which frequency for the patient for our HIV positive patients who are on ARVs, because we are very afraid that we might let the patient go being overweight. So which frequency should we measure, and what the waist, the height on waist, and the weight? So what would you recommend?
Can you hear me?
Yes, very good.
Okay. Well, of course, we know from the evidence over the last 20 to 25 years that the waist circumference, or even the waist to hip circumference, is most likely the best predictor for complications and hazards. Although I personally believe that if you measure together the waist circumference and the changes in BMI, you will have a high discrimination on risk. That is overall for the overall risk determination and prediction. If, however, we go back to the metabolic syndrome, which has a very likely risk prediction more for diabetes than for cardiovascular outcome, the best predictor and the easy and the cheapest predictor is the combination of the waist circumference plus the measurement of levels of triglycerides. If these two parameters are elevated, then that patient runs a very, very high risk. And if you ask about the frequency, I think if we do that, of course, by the early assessment, and afterwards, after 6 and after 12 months, that I think is the general recommendation. If, however, you see a patient who is in the initial period gaining a lot of weight, let's say within the first 3 months, then you can go somewhat earlier in the risk profiling with this approach. But that is the main purpose, the easiest one and the cheapest one.
Okay, very good, very interesting. And there is an emerging evidence that suggests that so-called healthy obesity patients have an increased morbidity compared to those with normal VAT and SAT. Can you comment?
Yes, that's true. And one of the major reasons and background that patients with a large amount of VAT is just a reflection or an expression of what I described as ectopic fats. That's the easiest way to look after it. You just see a patient with an abdominal belly, or you can measure it with the measurement of the waist circumference. But it at the same time reflects fat in the liver, fat in the muscle, fat in the heart, the epicardial fat, which is enormously harmful, and also fat in the beta cell, which then finally may lead to diabetes development. So indeed, if it is possible, but that is in epidemiological approaches, and in daily life more complicated to perform a CT scan. But I think we know that with each centimeter increase, or hopefully also decrease, with 1 centimeter increase in the waist circumference, you can accept that there is approximately a 5% change in real amount of visceral fat.
Okay, thank you. And so we've got another question that I might try to answer regarding osteoporosis and the fact that I've brought to you some results regarding the prevalence of osteoporosis in patients taking tenofovir lafenamide compared to tenofovir disoproxil. And it looks like from early data that osteoporosis risk is higher on TDF than on TAF. And one of the questions was, well, if we give TDF with unboosted PI or a drug without booster, would it be the same prevalence? Well, the emerging data are on the side that TDF without a booster might not trigger osteoporosis. So probably when you associate TDF without a boosted PI, the risk of osteoporosis is exactly the same that with CAF. But we need to get more data on the long term with the use of TDF without a booster. Another question is more regarding the balance between the TAF and the increased risk of dyslipidemia compared to tenofovir disoproxil without a booster, and the decreased risk of dyslipidemia, and the balance between the risk of osteoporosis and the risk of dyslipidemia, and especially in aging patients, and especially regarding my talk with aging women. And that's definitely a balance that you have to make. If you target TAF, then there might be no real impact on osteoporosis, but there is an impact on dyslipidemia. And when you prescribe TDF, then you will have less risk of dyslipidemia. And then you have to associate TDF with no booster. So maybe give a non-nuke, for example, or anti-integrase, but no boosted PI, and then you will have no impact on osteoporosis and no impact on dyslipidemia. And then there was a question regarding the effectiveness of diets on weight loss versus other approaches like medication, for example, GLP-1 drugs. And that's for you, Luc.
Well, on average, we know that still 5 to 10% weight reduction, which is feasible with a good lifestyle support, that 5 to 10% weight reduction may lead to an improvement of the classical risk factors that we described, the glucose, the lipids, and the blood pressure. And that's, or as we have explained, the most important drivers of the metabolic syndrome and the subsequent risk. However, if you would like to observe a change and a marked improvement of sleep apnea, of cancer development, and of cardiovascular outcome, then you need a result or a success beyond 10%. That is the reason, by the way, why in so many studies we have observed that with bariatric surgery, where we have the 20 to 30% weight loss, that there is proof of a decrease in cardiovascular outcome, which was not the case in classical lifestyle interventions, such as we have seen in the famous Look Ahead trial in the US. However, if you look later on, or if you analyze the patients who had a weight loss beyond 10%, even with lifestyle interventions such as in Look Ahead, then a benefit for cardiovascular outcome was present. That is the reason why the modern, newer GLP-1s, and there are nowadays once weekly approaches that give weight loss that will go beyond 10%. And for instance, with the newer semaglutide, which is already approved for diabetes treatment, not yet approved for obesity treatment, it's in the process of development. There we have weight losses with the baseline BMI around 35, we have observed weight losses that go clearly beyond the 10%, in many patients, in half of the patients, a weight loss close to 15%. So I think that is the future, but always concomitant with lifestyle intervention.
Okay, and that's exactly a remark from the audience, that perhaps all ART should be prescribed with daily 30 minutes of exercise and a healthy diet.
Absolutely.
We completely agree with that. Okay. So I think that we have reached the end of this Q&A session. I would like to thank you for attending this symposium, and I wish you a very nice conference, a second day conference. Thank you. Goodbye, and thank you, Rick, for joining us today.
And thank you, Corinne, for sharing.
Thank you. Bye-bye.
Bye-bye. Have a nice day.